you so much, everyone, for joining us today. My name is Sharon. I work with Insurance Advisors Direct, and we are hosting the Canadian Medstore webinar today with Bill and Amber, and I'll let them introduce themselves shortly here. But just a few things to get out of the way, some housekeeping. The Q&A box is on the bottom, and Amber's going to be answering your questions during the webinar based on what you ask her on there. And if it's anything that we need to do after the webinar, then we'll just hold that to the end. However, if anybody has questions, like I said, put those in the Q&A box. And we'll begin here with the Canadian Medstore. So I'm happy to be joined here with Bill and Amber. So I'm going to hand that over to them and then let them get started.
Thanks, Sharon. I appreciate it. As Sharon said, my name is 𝗵𝗲𝗄. I'm the founder of a company called the Canadian Medstore. Even though we're called the Canadian Medstore, we're actually located in Tampa, Florida. We've got 7 locations throughout the state, and we service clients in all 50 states right now. So I want to give you a little bit of a quick background, and I'll introduce Amber throughout the conversation. But if you have any questions, please feel free to just post, put them into the chat. Amber can kind of jump in and let me know when those questions pop up. But I wanted to give you a real quick background about myself so you understand who you're speaking to. Unlike everybody on this call, I didn't come from an insurance background. I'm not a benefits professional, or at least I didn't used to be. I got involved in the world of lower cost prescriptions and what quite honestly has kind of become my lifelong mission now. About 25 years ago, my brother was diagnosed with non-Hodgkin's lymphoma and went through a bone marrow transplant. And some of you who have been in the industry as long as I have might remember that was a time when we were hearing a lot of stories about people that were going to Canada to buy their prescription medications. You folks in Michigan are probably more familiar with it than the rest of the country. But here in Florida, it was something that really hadn't been heard of about a lot, but there were some conversations about it happening. Because of my brother's diagnosis, I can tell you that even 25 years ago, his treatment and his anti-rejection medication he needed from his bone marrow transplant was going to be tens of thousands of dollars, which was just simply unaffordable for us. We were hearing stories about folks that were, lived in Maine and Michigan and Vermont that could drive over to Canada and buy the prescriptions for less expensive. So that's what we did. We traveled to Canada. We were able to go from Detroit, Michigan over to Windsor, Ontario, and buy my brother's medications that was running tens of thousands of dollars for just a few $100s. What was so interesting to us was it was the exact same medication manufactured by the same manufacturer in the same facility. The difference was in Detroit, the medication was costing, $10,000. And in Windsor, Ontario, just 10 minutes away, it was just a few $100s. So when I came back to Tampa, I spoke to a physician friend of mine. Again, some of you older folks on the call might remember back prior to Medicare Part D being law, folks were really struggling paying for their prescription medications. They were leaving their group plans. They were able to pay for their health care by going to a doctor or going to a hospital because they had a Medicare supplement or they had some type of coverage. But once they left their group health plan, their supplement would cover their doctor visits or their hospital visits, but it was the prescription drugs that were causing people to go bankrupt. And what we recognized is if you lived in Tampa, you couldn't just hop in your car and drive over to Windsor. So we opened a company called the Canadian Medstore, which helped people order medications from licensed pharmacies in Canada. So I guess the easiest way to describe what we do is largely what you're probably used to hearing about friends and neighbors that may drive over to Canada right now. But we do everything through mail order. So our pharmacies in either Windsor or Winnipeg mail the medications directly to the individuals here in the U.S. Interestingly, about 5 years into our business, they tried to pass legislation that made it illegal to order drugs from Canada. Most politicians figured out that was political suicide and decided that they didn't want to do that. They certainly didn't want to alienate the senior voters. So the drug companies started to embargo products to Canada, meaning that they would say, we're only going to ship enough product to Canada to make so there's not enough available to ship to the United States. And that caused us to look to other parts of the world. And what we discovered is that there were other first world countries with top tier health systems like the UK, Australia, New Zealand, that were also able to offer those prescription medications at a whole heck of a lot less expensive. So right now, we don't only source our medications from Canada, although we do the majority of the drugs, especially the injectable medications, from our pharmacies in Canada. We have sources through pharmacies in the UK, Australia, New Zealand, really from all over the world. So what I'd like to do is kind of give you a real quick history, because what Tammy and Sharon asked us to talk about today is how would we be able to work with your clients to help them save on their prescription medications, especially you folks. And my understanding is that the majority of people on this call work in the Medicare world. And if any of you don't know, I'm assuming that you've probably been, living under a rock for the last few months, but there are some major changes happening within Medicare, especially the prescription drug plans. It's my personal belief, and I've heard this from other people, that it's going to be, Part D Armageddon. The world is going to be totally different in just a couple of months from now. And I know a lot of agents have talked about, not knowing how they're going to handle all the volume. Some people just saying, I'm not going to do it anymore. It's my personal belief that if you latch on this year, really get engaged, help your clients, there's going to be a lot of agents that aren't servicing correctly. And if you service those clients this year, especially, you're going to lock in that group of clients for years and years and years. So let's just talk real quickly. Because we usually get 3 questions from people. We get the number 1 question: is it legal? Can you order medications from Canada? I'll address that. Second question we get all the time is it safe? Are the medications that come from Canada safe to take? I'll address that. And then the other question we get all the time is, once people figure out that it is legal and that it is safe, the question is, why the heck is it so much more expensive here in the United States than in pharmacies in Canada and Europe and Australia and New Zealand? So for the next 5 or 10 minutes, I'm just going to real briefly go through the history of the healthcare system here in the US. And I think it'll help kind of put that light bulb off, so you'll understand why we're paying so much more than the rest of the world for our prescription medications. And then we'll talk about how we can help your clients ordering medications through Canada to lower their costs. So I'm going to share my screen real quick, and we'll get into that. And again, if you have any questions as we're moving forward, then feel free to just put a note in the chat, and Amber will answer those questions for you. Can you see that screen, Amber? I'm guessing yes.
Yes, you can.
Okay, perfect. Okay, so again, I told you who we were, where we came from. This is actually a pretty old cartoon that I always like to show to people. It's not very new. It's actually from back in, I think, 2006. I think what that really tells you is that this is not something that's been happening just in the last few years. For decades now, people have been going to Canada to buy their prescription medications. Again, I'm probably preaching to the choir. Often when I speak to people in other parts of the country, they don't really understand the whole idea of going to Canada as well as you folks do in Michigan. But I'm sure everybody on this call probably knows somebody that goes to Canada to buy their prescription medications. So let's talk about the problem first. A lot of people on this call probably already know this because you work in the world, but I don't think that the people that don't work in the world of healthcare necessarily understand this. Currently, we're paying about 20 cents on every dollar of our healthcare dollar that it goes to prescription drug costs. So out of every dollar we're spending on healthcare, about 20 cents of that dollar is going to prescription drugs. That's even higher when you get into the Medicare world. Estimates are as high as 30-something% that's going towards prescription drug costs. What I think is more telling about this slide, though, is that back in the 1990s, when there was first talk about creating prescription drug coverage through Medicare, the cost was only 7%. And at the time then, we were talking about people going bankrupt over their prescription drug costs. And if you go all the way back to the 1960s, when Medicare first became law, we were paying less than 2% of our overall healthcare costs for prescription drugs. I like to share this slide with you just because as we go through, we won't have a whole bunch of time to talk about the history today, but I always talk about whenever we create a government program that's supposed to lower the cost of care, you'll notice that as those things come into place, whether it's Medicare Part D through the Medicare Modernization Act, whether it's the ACA, any time that they tell us that we're going to lower the cost of healthcare through a government program, in actuality, the cost of care usually goes up, and it goes up by 3, 4, 5, times. I kind of think that's going to happen. I'll talk about this a little bit with some of the changes through the Inflation Reduction Act. $35 insulin is an example that looks really good on paper to the average individual who maybe is filling a prescription. Some people are going to be impacted positively by that, but the system overall is actually going to cause the cost to go up even more and more and more, and cause the system to implode quicker than I think is recognized. But $35 insulin sounds really, really good politically, and it's a really good optic. And quite honestly, some people are going to be impacted positively by that, but the system in general is not going to really turn out to be, it's not going to be what everybody is preaching it to be. If you leave with anything today, I think from a statistic perspective, then I think this is the one that always impacts me the most. 36 million Americans don't fill a prescription in the US each year because of cost. The reason that's such a telling statistic to me is that 36 million Americans is about 10% of our population. So that means that everybody on this call knows somebody, is working with somebody, one of your neighbors, somebody you're going to church with, somebody that your kids are going to school with, is making a decision not to take their prescription drugs, to skip their inhaler, to split their pills in half, something like that, because they can't afford the prescription medication here in the United States. Real briefly, I'd like to talk about the EpiPen. I know this is a really old story, but it speaks pretty specifically to the system, the healthcare system here in the United States, specific to prescription drugs. And it also tells the difference about what prescription drug costs are here versus Canada. So those of you that don't know the story about EpiPen, it's a drug that was been on the market for about 50 years now. EpiPen was manufactured. The manufacturer actually bought the patent from another company who didn't create the medication or discover the medication. They created a pen that allowed for that to be quickly administered to somebody who is suffering from anaphylactic shock. Pretty important, because if you're a 5-year-old who suffers from bee sting allergies, it's kind of difficult to, pull out the syringe, draw it from the vial, and then inject yourself. So the EpiPen was really quite a good development. But the company who actually was making all the money on it didn't create it. They actually just bought the patent, and then they manipulated the spring in the patent and extended their patent for about another 10 years. Because of that, because they were the only manufacturer and there was no competition for them, they raised the price of the prescription medications. Now, on my side, on the pharmacy side, we saw that that prescription was going from $200, and over about a 4-year time period, the price was almost doubling each year. So it went from $100 and something to almost $300, and then from $300 to $400 or $500, and increased to here in the United States, where the average cost was about $750. The slide shows $600, but in actuality, at the peak of this, the price of the medication got up to about $750 in the United States. In England, they were paying $69 for the prescription medication. In France, they were paying $100 for the exact same EpiPen. In Germany, they were paying the most out of all of Europe. They were paying $200. But here in the United States, we were paying $600, $700, even $800 for the exact same EpiPen. There was an investigative reporter in Buffalo, New York, who visited 10 pharmacies in the Buffalo, New York area, filled the prescription, and found that the average cost of the EpiPen in Buffalo, New York was $756. She then drove over to the border to Niagara, Canada, literally 10 minutes away, and found that the average cost of the EpiPen was $94. Now remember, EpiPen didn't have a generic at the time. There was only one manufacturer that was manufacturing the product for the whole world. So the Canadians were getting the exact same product manufactured by the same manufacturer in the exact same facility. One was just labeled for sale in the United States. Those were the $756 EpiPens from Buffalo, New York. Another one was labeled for sale in Canada, and those were $94. It's interesting, in the article that one of the pharmacists actually apologizes to her, saying that the price of $94 was so high that if she was a Canadian citizen, she would only be paying about $5 or $6 with the co-payment. But I'm not saying that to tell you that the Canadian system is better. What I'm trying to tell you is that the $94 was not the Canadian prescription coverage through, Canadian insurance. That was the retail price that she was paying as an American buying a prescription over the counter there in Canada. When Alex Azar was going through his hearings before he became Health and Human Services Secretary under the Trump administration, he was asked by one of the senators about this specifically. And what he said, as I think was very, very telling to the system in general. He said when a patient goes to the pharmacy, they're getting the sticker. Nobody was ever supposed to pay that list price. And what he was saying by that was he was saying that most individuals were only supposed to be paying their copayment. They were supposed to just see the $45 or $50 copayment, not recognizing that the price of the medication was actually $600 or $700. If there's any probably silver lining to the story is that EpiPen became such a big story because it impacted children that the average person that doesn't work in the benefits industry like we do started to see the cost of prescription drugs. And the main reason for that was because of the Affordable Care Act. Employers who used to offer co-payment plans through fully insured chassis now started to shift to high deductible health plans. So a lot of individuals who never used to see the real cost of the prescription hadn't hit their deductible yet. So for the very first time, they were actually seeing the cost of prescriptions. But what Azar was saying is nobody was ever supposed to see that. They were only supposed to pay the co-payment. You and I as taxpayers or you and I as employers were going to pay the full price, but the average individual was never supposed to see that price. We don't have time to talk about the whole system and why the Europeans are so much less expensive than we are here in the United States. But basically, the gist of it is during World War II, in the War Powers Act, Congress allowed for employers to offer health coverage to employees at a tax deduction, and the employees would get they would get that benefit at no tax rate. That didn't happen in Europe. Europe actually switched to a nationalized health system because after World War II, there was basically no infrastructure left, so they had to go to a national health system. Like most programs here in the United States, the tax benefits for health insurance was not supposed to last forever. It was only supposed to last through World War II and a little bit after. But like everything, once you give somebody something, it's very, very hard to take it away. So that became our system. Same thing with Europe. Most of the countries were only going to have their nationalized system during the rebuilding years after World War II. But like everything else, once people came used to it, it became very, very hard to take away the national system. So in Europe, they gravitated towards a national healthcare system. Here in the United States, we gravitated towards a employer sponsored health system. Why does that matter to people talking about Medicare? Mainly because of when we created Medicare, remember that the big issue was people were leaving their group insurance, and that's when we saw poverty really take off. We saw the retired population starting to not be able to afford their health care or basically afford the cost of living. So there was a big push towards Medicare. Remember, when Medicare was created back in 1965, there was no prescription drug coverage. The reason for that is the slide that I showed you earlier. Is it wasn't because they didn't want to give old folks access to prescription drug coverage. It was because at the time in the 1960s, nobody expected to see drugs that were costing $800 a month, $8,000 a month, $800,000 a month. We were only paying less than 2% of our healthcare costs to prescription drugs. So when Medicare was created, there was not really even much thought. If you look at the congressional record, there's only a little bit of talk about prescription drug coverage because pharmacology had not advanced at that point. You get into the 1980s and 90s and you start to see the blockbuster drugs come out for the first time. And all of a sudden, prescription drugs start to become a high cost driver in healthcare. The other thing that happens is the pharmaceutical industry becomes the most powerful lobbying group in all of Washington and every state capital. So the pharmaceutical industry becomes the most powerful, not only healthcare lobbyist, but the most powerful lobbying group in the entire country. Once again, here's that slide. We introduced Medicare Part D in the early 2000s. And you'll see that it doesn't actually lower the cost of prescription drugs. It actually increases the cost. But how did that come about? This is very, very important to our conversation today. Under the Clinton administration, they were looking at overhauling the entire healthcare system, including Medicare, and going to more of a nationalized system like they saw in Europe. What happened, though, is the Clinton administration didn't really partner with the insurance industry, didn't partner with the healthcare industry, and basically they failed. The pharmaceutical industry, the hospital groups, the doctor groups, the insurance groups all lobbied hard against the Clinton administration, and it never passed. Well, you go forward a couple more years, George Bush becomes president, and a couple of things happen. Number one, we have a Republican in Congress who typically wasn't really a big the Republican Party wasn't typically a fan of lowering prescription drug costs or doing anything that would appear to be drug price controls. But the other thing that happens is not only do the Republicans control the House, but for the first time in 50 years, do they control the White House, but for the first time in 50 years, they control the Senate and the House of Representatives. So they're able to push through the Medicare Modernization Act of 2003. And they do that in a couple of ways. Number one, they recognize that seniors now, number one concern is no longer outliving their money. It's affording healthcare, specifically prescription drugs. So they recognize that a huge voter block is going to be beneficial to them. The other thing, though, is they learn from the Clinton administration's mistakes. And what they do is they don't go against the insurance industry or against the hospitals or against the doctors or against the pharmaceutical industry. They actually team up with them. And they do that by going to the insurance industry and saying, we're going to create this program that's going to be government subsidized, but you're going to be able to sell private health insurance. And you're going to sell a whole heck of a lot more plans. 40 million Americans are now going to need prescription drug coverage through Part D, and you're going to be able to sell Part D plans. So, and they also obviously expand Medicare Advantage, things like that. But that causes the insurance industry to say, hey, we like this. But they still had to win over the pharmaceutical industry. So what they did is they went to them and they said to them, we want you to get on board here. And the pharmaceutical industry basically said, no way. We learned our lesson when we allowed for negotiation through Medicaid and through the Veterans Administration. We're not going to do it with Medicare, the largest payer in the country. So the Bush administration basically makes a deal with the devil, and what they tell the pharmaceutical industry is that they'll pass the law as long as they make part of the legislation that they can't negotiate drug prices. So what that means is until very, very recently, under the Affordable Care Act, and as you all know, that doesn't really impact that many drugs, it was actually illegal for Medicare to negotiate prescription drug prices with the pharmaceutical industry. So what that means is the largest healthcare purchaser in the country, really in the world, being Medicare, couldn't negotiate the price of prescription drugs. Everything else within the world is negotiated that way. Everything else in healthcare, if you know anything about the group chassis, is usually based on, a knee replacement surgery is going to be based on a certain allowable amount through Medicare. Well, what does that mean? What's the allowable amount for Medicare prescription drugs? Really, whatever the prescription drug companies could charge. So you saw not only prescription drugs go up massively in the Medicare industry, but you saw it across the entire chassis. You saw it, of course, in the group world too, because there was nothing really to base it on. And because the drug companies were so powerful and were allowed to protect their patents for so long, there was less competition with generic medications. And obviously, that's why we're in the situation we are today. Prescription drug costs, when you compare this to all the other countries, this was done under the Trump administration. When you remember, he was pushing his America First strategies and talking about all that. What they did is they compared the top 100 Part B drugs. I say B like as in boy, prescriptions that you're going to receive in a clinic or at a physician's office or in a hospital. The top 100 drugs, apples to apples, so the exact same brand name drug. They compared the U.S. price to these other 8 countries and found that we were paying on the average 56% more than the other 8 industrialized countries for the exact same medications. The other thing I like to point out about the slide, and I challenge most people on this call, I think if you were in Paris, France, or you were in London, England, and you had to go fill a Z-Pack because you needed an antibiotic, or you needed to fill an inhaler, or you need to fill a prescription, you'd feel very, very comfortable walking into a pharmacy in Canada or London, England, or Paris, France, and filling your prescriptions. So we're not talking about taking third world countries and comparing their drug prices to ours in the United States. We're talking about first world to first world, apples to apples. I'm going to breeze through this real quick and get into how we kind of work with clients. But I just was kind of showing you, just saw the slide with Governor DeSantis, who's here in Florida. This isn't just some story that some crazy guy that lives in Tampa, Florida is telling you. This isn't some Bernie Sanders story. This is happening across the country. The state of Florida became the very first state to allow for their state employees to order prescription medications from licensed pharmacies in Canada. There's currently 11 other states with similar legislation. The state of Utah actually has an arrangement with a pharmacy and a hospital group in Mexico because they found that they can send their patients or their employees down to Mexico for certain surgeries and things like that and infused medications for a whole lot less expensive than filling it right there in their home state of Utah. Let's talk about safety quickly. People always talk to us about saying, well, I keep hearing that the drugs from Canada are unsafe. And I'll let you know if you're talking about maybe responding to some spam email that you get, or some cold call from somebody telling you you can fill your Viagra without a prescription. Then yeah, I would probably be careful about that. But if you're going to an actual brick and mortar pharmacy like we are in Canada, you're getting the exact same medication actually manufactured by the exact same companies. One's just labeled for sale in Canada, another one's labeled for sale in the US. Like I said, I live here in Tampa, Florida, so Publix is our number one grocery chain here. People talk about, again, are the prescription drugs safe from Canada? And sometimes the FDA has pushed back and said they can't certify the prescription drugs from Canada as safe. Now that's changed recently, but I always tell people, please go to your seafood department in your local Kroger or whatever your local pharmacy or your local grocer is. And I guarantee you're going to see, previously frozen tilapia from Vietnam and farm raised shrimp from Belize. And you're probably going to see, Canadian salmon for sale. And somehow the FDA and the pharmaceutical industry wants you to believe that we can certify that the previously frozen tilapia from Vietnam is safe for you to feed to your kids, but they somehow can't certify that the EpiPen manufactured by a U.S. company in a U.S. facility and shipped to Canada is somehow unsafe. It just doesn't really hold water anymore. Amber's heard me say this 100 times, but I tell people all the time that I visit my pharmacy in Canada about every other month, and I've yet to see dead Canadians floating over Niagara Falls because they're getting fake medication. They're getting the exact same medication we are here in the United States. The only difference is they're negotiating their pricing. We're here in the United States, we're not able to do that. And I'll leave you with this part until we get into the strategies. Again, it's not just some crazy idea that some individuals are doing, or some folks that, some seniors that live in Detroit are of driving over the Windsor. There's currently over 2,000 counties, municipalities, private employers that we're working with, not just individuals, also with public entities, municipalities, school districts, private manufacturers that are utilizing our program to source medications from international pharmacies. This is the last thing I think is pretty important to speak to the fact of the prescription drugs being safe. Former FDA Commissioner 𝗁𝗁𝗁𝗁, who's also a doctor, he's become kind of famous because he's now sitting on the Pfizer board for the COVID vaccine. So he's often a talking head on a lot of shows. But when he was asked during congressional testimony about going to Canada, he said what I just said to you. The FDA commissioner, the man tasked with protecting the U.S. drug supply, said exactly what I said. If you walk into a legitimate pharmacy in Canada, you're going to get the exact same medication because the Canadian system is a first-class regulatory process, just like we have here in the United States. So let's talk real briefly about one example that I want to give you, and then we'll talk about the strategy and take questions. A drug that we talk about a lot in the Medicare world is Eliquis. We actually need to update this slide because I just looked it up this morning, and the retail price on Eliquis now is around $650. It's no longer $550. But I just went on to GoodRx, looked up the prescription Eliquis, put it in there. Even with the coupon, you'll see that from this slide, it says about $450 a month. The price is around $550 with a coupon, $650 retail. The exact same medication through the international pharmacies are $73 per month. So a drug that's costing somebody $650 here in the United States, $650 going to their donut hole, $650 going, that they have to pay until they hit their deductible if they're not on Medicare, would cost them $73 through Canada. So what we talk about all the time is if you have that individual who you're trying to pick a Part D plan for them, and you have to buy a more expensive plan, a $70 a month plan or a $50 a month plan, because you need to get that Eliquis covered. And I'll give you the example that we deal with all the time. Somebody's taking 6 or 7 medications, but 5 or 6 of those drugs are inexpensive generic drugs. The one expensive drug they're taking, like Eliquis or Xarelto or Janumet or Advair inhaler, is the one that's causing them to have to buy a more expensive prescription drug benefit. Or maybe they have to change their their Part D, or I'm sorry, their Medicare Advantage plan because the plan that they need does not cover that drug. So now they need one that also covers their doctors and the drug. You create a lot of confusion for the individual. Well, we have a lot of agents that are saying, wait a minute, if we can get that Eliquis from Canada for $73 and your copayment was going to be $65 anyway, we don't have to buy the $70 a month drug plan. We don't have to change your Medicare Advantage plan from one to another, or to change doctors because you need to have your drug coverage under your Advantage plan. We're just we're a tool for you to help utilize that. I think what's important to tell you is we're certainly not going to replace Medicare Part D. We don't intend to do that. We don't ever want an agent to say, we're just going to send people to Canada and not buy a Part D plan. We're here to be another tool in your chest to help fill that problem that you might run into. The other example we hear all the time is the person who you helped back in November. You picked a plan, everything was perfect. They were taking some generic medications. You put them in an inexpensive Part D plan, and halfway through the year, they call you and they say, hey, that plan was working out great, except now I just got prescribed this new drug called Eliquis, and I've got a big deductible on my health plan, and now I have to pay $650 for the medication. What do I do? Well, a lot of agents then will refer them over to us. We'll order their medication from Canada until the open enrollment period comes around, and you as their agent sits back down with them and decides, is Canada still the best option for the Eliquis, or can we get you into prescription drug benefit that'll fit you better? Let's talk about some of the changes that are going to be happening this year. Obviously, we know that there's going to be a $2,000 max out of pocket on prescription drugs. So I think the example that we use a lot about utilizing Canada to avoid the donut hole may not be the best strategy anymore, because you may want to get somebody to that $2,000 maximum out of pocket as quick as possible so they can get the 100% coverage. The problem is, until we really start to see those drug benefits, I'm not sure how to totally explain to you how to work that, because we don't really know what the benefits are going to look like. But my estimation, and from what I'm hearing from a lot of the FMOs and carriers, is that we're going to see massive increases in prescription Part D premiums. So it's not going to be uncommon to see a premium that's well over $100 any longer. You're going to see the formularies getting much, much skinnier, meaning that only certain drugs are going to be covered in the area. Now, people have pushed back to me and said, but Bill, they have to cover X amount of drugs within a category. That's true, but it doesn't define what tier that they have to be covered at. So you may see a lot more of those really expensive drugs being pushed up. The other thing is, you're going to start to see Medicare Advantages plans get really scaled back. They're going to have to make up for the cost that the insurers now have to accrue through the changes through the Inflation Reduction Act. Therefore, you're going to see major changes to Medicare Advantage. The other thing I think you're going to see is individuals who maybe never wanted to look at Advantage before, wanted to stick with their supplement and stick with their inexpensive Part D plan. I think it's going to be more and more difficult to find those inexpensive Part D plans. So you may see people who never wanted to look at Advantage before want to gravitate from a supplement to an Advantage plan. And I think that creates an opportunity for you to help educate that person, or help tell them maybe they don't have to move if they have an opportunity to fill their prescription drug from Canada. Or maybe they do want to move, but now you're going to have issues finding all of their doctors that accept the Medicare Advantage plan, plus all the prescriptions that are going to be covered. So think about Canada as an option to help you lower those costs, but also not only from a cost savings perspective, more from a how do you help that client pick the right plan, and is this another tool in your chest to help them do that? Outside of Medicare, I can tell you that we work with hundreds of individuals that are on high deductible health plans. My wife, being one of them, takes a very expensive inhaler. Thankfully, we're healthy other than that. We never hit our deductible, but we have almost an $8,000 deductible. And her inhaler that would typically cost us $400 a month cost about $60 through Canada. So I fill that prescription through Canada instead of paying the $400 and never hitting the deductible anyway. What's important to know about that, though, is if somebody orders a medication from Canada, it would be considered outside the network. So it's not going to count towards their deductible. But you probably know the statistic that 80-something% of the individuals on high deductible health plans never hit their deductible anyway. So as long as the individual understands that, it's something that can be beneficial. Individuals that are on short-term health plans, Often the big concern there is, well, what about prescription drug coverage? This may be a way to help somebody go into a short-term plan and also get their prescription drug coverage from Canada. We know that there's still individuals that are uninsured, even after the ACA. And then obviously, if you work in the group world, we work with, like I said, over 2,000 self-insured employers that currently order medications through us. I'm going to leave it at that. What I will tell you is that working with us, let me just say that we're not like your typical online company. We're not going to be just a call center or a website somewhere. We've created what we call our agent concierge team. So when you refer a client, Amber, who's on the call with me today, her or somebody from her team will be the actual person that's talking to your client. When you talk to Amber and she introduces you to somebody on her concierge team, that's going to be your go-to person. So you can go to them with a question about prescription drug costs. Hey, is this going to make sense if we order this drug from Canada and help with this other Part D plan? They're going to be there as your person. And the reason we created that program about 2 years ago was because when we were hearing from agents like the folks on this call, we know how hard it is and how hard you've all worked to build your book of business. And the last thing you want to do is just send somebody to a website somewhere or to a call center somewhere. You want to actually hand them off to a real person. Then Amber can take it from there, but she'll also be able to communicate with you. Hey, we spoke to Mrs. Smith. We're getting a prescription for her from her doctor for her Eliquis. We're going to order it for her. She's going to get her prescription in, 2 to 3 weeks. Real simple stuff like that. But I want you to know that when you're working with us, you're going to have access to an actual concierge who's going to help walk you through the process, provide you a price list, updated price list on a regular basis, marketing materials, things like that. So mainly you're going to want to go to IAD. They'll make the introduction for you, and then we'll push that through. So is there anything, Amber, that I pretty much missed out on there that we probably need to touch on from the process?
No, I think you did a great job. There are some questions in the chat.
Sure. Yeah.
So Kurt said he's asking about China and plays a global role in formulating prescriptions worldwide.
Mm-hmm.
You're giving a lot of reasons of why to buy for Canada. But if most prescriptions are formulated in China, it doesn't matter whether I buy prescriptions here or in Canada. He also followed up with, in other words, it's safe to buy prescriptions in Canada because we currently allow China to formulate our drugs. I would imagine China supplies Canadian pharmacies as well.
Yeah. So to Kurt's point, you're kind of right, Kurt. If you really want to talk about the issue of drug safety, I don't think it's whether a drug's coming from Canada or the United States. The scary part is when you look at some of the drugs that we're buying here in the United States, and if you read some of the stories that have come out sometimes from some of the drugs that were manufactured overseas, you're right. I think there's probably as big of a risk of you going to a pharmacy in the U.S. and getting a medication that's inferior than there would be ordering from another, sanctioned international company. The one thing I do want to warn you about it is there was a lot of talk, especially during COVID, about drugs coming from Canada. If you look at the majority of drugs that are manufactured globally, the number one manufacturer of prescription drugs is actually India. The concern with China is most of the ingredients in a lot of the drugs come from China and then are shipped to these other manufacturers all throughout the world. So one of the reasons why there were such shortages on drugs during COVID was because the actual stuff that we used to make the drugs was coming from Canada. And there's starting to be a lot more inshoring of that, drugs coming back to being manufactured in the US. But you are right. If you go to your pharmacy and, if you walk into your local Rite Aid or CVS, if you look at the actual bottle of the manufacturer, I would tell you that there's probably an 80% chance that the drug was actually manufactured, especially if it's a generic, that it's actually manufactured overseas. And you're correct. If you're going to get it from a Canadian pharmacy or a UK pharmacy or a US pharmacy, if it's manufactured by one of the manufacturers that you and I both know, there's a very good chance that the ingredients, whether it's from Canada or the US, are actually coming from China. And that's just the manufacturing of prescription drugs in the global world that we live in.
And then the other question that came in was, hasn't the donut hole effectively been eliminated at this point? Because you did touch on
Pretty much. Yeah, pretty much. The thing I think you're going to see is a shift in cost. So you're totally right. Where we used to be a huge benefit to people to avoid the donut hole, or if they hit the donut hole, they would come to Canada to get their prescription, because they used to be in that donut hole area. They had to pay the full cost until they got the catastrophic. That's pretty much gone away. So people go right from their $2,000 out of pocket to then basically having their coverage kick in. What I think you're going to see is a huge shift in cost, meaning you're going to see premiums go through the roof, you're going to see co-payments go through the roof, and you're going to start to see premium or formularies get very, very skinny. So drugs that used to be covered at a $45 co-payment may not be covered any longer, or that $45 copayment may now become a $150 copayment because everything's going to move to a tier. Any of those expensive drugs are going to move into a tier 4. Again, until we see the plan design, nobody really knows what it's going to look like. I can just tell you, and I'm not a mathematician, but when you look at the reimbursement that the Medicare Advantage and the Medicare Part D companies are getting, versus what they're going to have to cover, you have to understand that the federal government shifted the cost. Medicare Part D plans used to not really care if somebody hit a donut hole because it didn't matter to them. They were getting the same reimbursement if somebody was in the initial coverage period, donut hole coverage period, or catastrophic coverage. They got paid the same. Now the insurers have to take on the lion's share of that actual cost. The only way for them to afford that is to shift and to say, where am we going to shift the cost? We're going to raise premiums, we're going to raise deductibles, we're going to make co-payments higher, and we're going to make our formularies a lot skinnier.
And then also Kurt had a follow-up question. So how will you help mitigate those high costs?
Well, I think what's important to know is the cost of like using the Eliquis example. If a drug is still going to be $650 here in the United States, you're going to see that, we know that we can get that medication from one of our international pharmacies for $73. So an individual going into that process knows that if they're going to order the Eliquis through the Canadian Medstore, they're going to be paying $73 throughout the entire year for that prescription medication. I think it allows for you, when you're planning and going through the planning process of picking a health plan, if you see a Part D, if you have to buy a $150 a month premium Part D plan just because they're taking an expensive drug like Eliquis, does it make more sense to keep them on a less expensive plan, allow them to fill their generic drugs through that, and then order the Eliquis through Canada? Because although their maximum out of pocket may only be $2,000, if now they're paying $100 and something a month in premium, there may be a cost benefit to continue to fill that expensive medication from Canada. I will tell you this, Kurt, if you have somebody that's going to be taking 2 or 3 expensive medications, I think all day long Amber's going to tell you, listen, we can help you for a couple of months, but you're going to be better off getting your client into their catastrophic coverage and let the 2,000 max hit. But if you have that individual, like our typical client, who maybe is taking one expensive insulin, or they're taking Xarelto, or they're taking Januvia, or they're taking Eliquis, that's where I think we're going to help them. What's important for you to know is, remember, we're just a tool in your chest. When you run into those situations and you're running those numbers, send that drug list over to Amber, and she'll tell you what the drugs would cost to Canada versus the US. The other thing that's, I think, it's important to know is, listen, you don't need to, if there's a generic drug, there's never a reason to go to Canada for that. If we're not talking about the $4 and $10 generic drugs. The drugs we're talking about are the ones that you all know: Eliquis, Januvia, Janumet. Amber will share the top 100 list with IAD, and they can get that out to you guys. Okay. That's what's important to know. Our joke in our office is, if you see it advertised on TV, if they're singing a jingle about it, then you probably know you can't afford it. You know what I mean? If you're seeing a pop-up ad, if you're seeing an ad in a magazine, those are the ones that we're going to help you with. You're not advertising the $4 Walmart generics anymore. It's the expensive medications that you all know, you all run into. Those are the ones we're going to be able to help out with. One other thing I want to touch on is the $35 insulin thing that I touched on before. 2 things about that. $35 insulin is great, but as we all know, a lot of the really expensive pens and stuff that people want are not covered under those $35 insulin benefits. The other thing is, when I talked about the shift there, remember what the legislation did was make that $35 insulin available to the individual, but it did nothing to control the cost to the insurer or to the employer or to us as taxpayers paying that. So in my opinion, you're actually going to see the cost of insulin go up even more quickly, because now there's no incentive for the manufacturer to lower the price. Because guess what? If an individual is only paying a $35 copayment, they don't care if the insurer is paying $1,000 a month for the medication. It doesn't matter to them. Everybody says they want to lower the cost of healthcare. The truth is, if they're paying a $35 insulin copayment, they don't really care. So we don't see any incentive for the manufacturers to lower the cost of insulin. If anything, we see an incentive for them to raise the price of insulin, because the individual is no longer making us think about it, because they're only paying a $35 insulin cost. And the politicians love it because it's a very good story to tell. Look what we did. We lowered the cost of insulin. They didn't lower the cost of insulin. They just lowered the copayment on insulin.
There are a few more questions. One is, while prescriptions are being processed for delivery in 2 to 3 weeks, what would the client do? I normally suggest that they, if they are about to run out, that they get a local 1-month supply, or ask their doctor for some samples, just to keep them on the medication. Now, with refills, we would be reaching out to them prior to them running out, so that they would have enough, that there would be enough time for them to continue their medication while they wait for the order.
And what's important to answer about that too, just so you know, typically folks that are ordering medications from us, every once in a while, I shouldn't say once in a while, it happens a lot, but people get a brand new prescription that's very expensive, and that's when they start to look to Canada. And in that situation, to Amber's point, we usually encourage them. We'll even contact our doctor for them and say, hey, listen, we're gonna do this order for this person, but they won't have the prescription for 3 weeks. Can you provide them with a month's worth of samples? We can try to help them with that. Sometimes they have to bite the bullet and fill the prescription one time at the local drugstore, and then they get the 3-month supply from us, and then every 3 months we can reorder it for them. But I think what's important to know is the average person is probably on a maintenance medication. So they've already been taking that medication for a little while. They're leaving a group plan. Maybe they're just learning about it because you introduced them to us. So they're already filling that prescription through their current benefit. So typically we don't run into that problem, but it does happen quite a bit. And unfortunately, we have to work to try to get them samples. And if not, they have to bite the bullet for a month until we can get the prescription to them.
And then I would say the last question that you can answer is, how do you compare with Mark Cuban's online pharmacy? Because I feel like that's come up a lot in my conversations with agents as well.
Yeah, I can tell you Cuban's program is awesome. I've actually had communications with some of his team because they're trying to figure out how to tap into the brand market. Cost Plus is great when it comes to any of those programs. I'm not a huge fan of some that I know are selling your data to other people, but like Cuban's program, some of those other ones that are out there are really, really great when it comes to generic drugs. But what I can tell you is Cuban's and everybody else's, if you go and look up Eliquis or something like that, you're going to see coupons, but they're going to be $100 coupon. Well, if it's a $650 drug and that's bringing it down to $550, if you can get that same exact brand name drug for $73 in Canada, we're still going to blow them out of the water on all that. But Amber's team probably refers people to those other programs when it comes to generic drugs on a daily basis. Again, what we're going to be able to help with are the brand name drugs. Cuban can do a great job with taking cost. What they're doing is they're buying a drug. They're saying we're going to increase it by X amount of dollars, which is why they call it Cost Plus, and that's what they sell it for. They're not playing the games that everybody else is in. The problem is, if there's only one manufacturer of Eliquis in the United States, Mark Cuban's buying it at the same price that everybody else is buying it at, which is going to be, $550, $650. They can't lower it any more than that. In Canada, because they've negotiated the price down, we can get the exact same Eliquis for $73. If you leave with anything today and you want to be angry and get your blood pressure up, understand that the other countries that we're talking about are buying the same exact drugs from the same exact manufacturers they're just paying a whole heck of a lot less for it because they're negotiating at a nationalized level. And what we're doing is giving your clients access to those pharmacies in those countries that have negotiated those prices down. The last thing I will say about that, though, is sometimes we'll be able to source a generic drug internationally because most of the other countries don't allow for the drug companies to continue to extend patents for longer and longer and longer periods. For example, the Viagra and Cialis for the longest time that are now available, as generics for a couple of dollars a pill that used to be $40 a pill. The generic was available in Canada and UK for about 18 months earlier than it was available here. So we were able to get even lower prices because we could source a generic drug. But in general, our typical client says, if I can get the exact same drug from the exact same manufacturer, I'm going to order that in brand name because a couple more dollar savings is not going to really make a big difference to me. But I hope that answers the question. 𝗃𝗵𝗴𝗀's going to be great on generics. You're going to want to come to us when it comes to the brand name prescription medications.
And then I think that we're out of time.
Okay.
Yes.
So Sharon,
everyone.
you just let us know.
Amber. Yep, sorry. Everyone out there, please reach out to us here at IED via email or give us a call at 800-381-0977. And you can either go to extension 129 for Tammy or 128 for myself, Sharon, and we'll be happy to get you in touch with these folks here that can help you out with your clients. And I hope you had some questions answered today. Hope you got some great information from Canadian Medstore. And I think this was a great webinar. So thank you, Bill. Thank you, Amber, for all the great information. I know we could go on and on about prescriptions and drug cost for hours, I'm sure, because there's so much to talk about with that. So like I said, we'll have this webinar will be available on YouTube if you want to rewatch the recording as well. And we should have that up for you by next week. So, and thank you everyone for joining us. I hope you got some great information today. So thank you so much, everyone.
Thank you.
Thanks, guys.
All right, bye-bye.